Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to the Rural American Surgeon. Our episode last week with Dr. Mel Johnson was just too packed with too many nuggets of information that I had to split it into 2 episodes so that I could share it all with you. So we're back with her again this week. Now let's get to the show. All right. Well, tell me what you want to tell me about Sentinel lymph node biopsy. So maybe like how you do it, and then all the other permutations and
Right.
Ways to get it up and going.
Yep. So again, the way we do it at Gunderson La Crosse and have for a long time, again, is doing our own lymphoseek injection, which that was new to me. I'd never done my own, but again, that sort of pulls out the needing that nuke med department there. So we use blue dye. We happen to use isosulfan blue dye, but many places use lymphozurin. I don't think it matters. And then we use lymphoseek, but there are, again, ICG is another possible way. If you happen to have ICG capabilities and you don't have a neoprobe, you could look into that. There's also a newer one called MagTrace. I've never used it myself, but MagTrace is selling themselves too, in that you can inject it. Like, let's say you're doing a mastectomy for DCIS, where we would normally do a sentinel node biopsy. You can inject MagTrace at the time that you're doing the case and not do a sentinel node biopsy. And MagTrace hangs around. My breast partner thinks it hangs around for about 2 weeks, but once you get pathology back, if there's an invasive cancer, you can go back and do a sentinel node biopsy. So that's something newer. Again, we are not doing that. We do blue dye and we do lymphoseek, but there are other ways of doing it. And I would say more companies are getting into that space. So you just have to look into what technology you want to purchase for your hospital.
So when do you inject? You said you inject the lymphoseek before they go back. So if they're in the pre-op holding bay where you inject it, all right. If they have a palpable mass, are you injecting the lymphoseek into the mass or in a subareolar location?
We do it we do an intradermal injection, upper outer quadrant, right outside the areola of the breast cancer breast.
Just that one spot.
That's it. It's about 0.4 mils. It's injected with like a 29 gauge needle and a little diabetic syringe.
And actually intradermal, so you're raising a wheel when you do that.
Raising a wheel, correct.
And you're prepping with some alcohol?
Yep.
And are you injecting any local beforehand, or you're just injecting that wheel?
No, just
okay. And what size needle do you use?
I believe it's our insulin syringe needle, so I think it's
like a 30
gauge. Yeah, and it comes preloaded. Again, our lymphoseek arrives that morning we get ours from UW-Madison. Even though we have a nuke med department, they don't deal in lymphoseek. So anytime they're even injecting, let's say for a melanoma case, same thing. They're getting it that morning from UW. So again, let's say you're a rural hospital in Wisconsin, you could order it as well.
I see a question on the melanoma. When you inject for the melanoma, I noticed that usually the radiologist injects 4 quadrants around whatever lesion we're trying to do. So that's what I was kind of asking if you did 4 quadrants on melanoma, but you're still having them do it the same way.
They do their own injection. I was called one day to inject for a melanoma patient for ENT because evidently the radiologist covering nuke med wasn't comfortable. So they told me their protocol was to do a 2-site injection for this particular melanoma. But again, don't let me speak for nuke med because I'm not normally the person injecting for them. But
got it. And so then you don't inject the blue. How do you inject the blue dye? After the patient's asleep?
Yes, we did. I still do 4-quadrant injection around the areola. So that was how I was trained to do it. I use 0.5 ml at 12, 3, 6, and 9. But there are many ways to do it. I have another partner who does his whole injection intradermally at that upper outer quadrant location, so the same location that they get the lymphoseek. I don't think any of my partners are doing it around the tumor itself or trying to approximate that. most of us are doing it around the areola. We have one new partner who just got out of breast fellowship. She injects, basically, she kind of fans it out all underneath the areola and does in there. Yeah.
So how about if you're leaving the nipple, and how about blue dye staining long term and trying to minimize that? Can you talk about that for just a second?
Yeah, I've really not seen it be an issue with sticking around. So I've not, at least when I see my patients in follow-up, I can't think of anybody that has a permanent tattoo from the blue dye.
And you said you're using isosulfan blue.
Isosulfan blue.
Yep. Okay, great. So we've talked quite a bit about sentinel node biopsy. Was there something else that you wanted to talk about relative to rural places, or have we covered it all?
I was just going to mention a couple trials that are ongoing, and I can direct people to a recent article that came out. Monica Morrow is one of the kind of national giants in breast surgery and has been for decades now. But she had an article in New England Journal of Medicine called, and this was in December of 24, called Sentinel Lymph Node Biopsy in Early Stage Breast Cancer. Is it obsolete? So just so people know that this is out there, it is not yet considered standard practice, but there are really two trials going on. One's called INSEMA, INSEMA, and the other one is called the SOUND trial. They are looking at, so especially the SOUND trial is looking at T1N0 patients that opted for breast conserving surgery, and they all had a negative axillary ultrasound and a negative clinical exam of the axilla. So again, T1N0, breast conserving surgery only, negative axillary workup. They were looking at all comers, including all types of receptors, pre and postmenopausal. But interestingly, 95% of the patients that are enrolled in that SOUND trial were hormone receptor positive and HER2 negative, and 90% were postmenopausal. So if you want to try to extrapolate these results, I think you really are probably looking at, again, hormone receptor positive, HER2 negative, and postmenopausal. But they were looking at not doing sentinel lymph node biopsy in those specific patients, so in your T1s. And their data showed they were missing about 9 to 11% of people in that group. By not doing a sentinel node biopsy, you have to accept you're going to miss 9 to 11% of people that would have a positive sentinel lymph node if you did it. The INSEMA trial was including T2s. So for T2s, we're talking about 2 to 5 centimeter tumors. They're missing over 20% of those patients that would have a positive sentinel lymph node. So again, these trials are ongoing, but they are making that tentative recommendation that maybe we don't need to do sentinel node biopsies in T1 patients. I'm old school. I've been doing this a long time. If I'm the patient, you tell me there's a 10% chance I've got a positive node, and you're not going to find that out. Because again, if you have a positive node these days, not everybody needs a full axillary node dissection. If you have 1 or 2 positive nodes, we're just putting those patients into radiation therapy instead. So when I read those trial results and see 10%, man, yeah, that might be okay if I'm 85, but if I'm my age, I'd say go ahead and do the sentinel node biopsy, because the risks of the sentinel node biopsy are so low, like risk of lymphoma from a sentinel node. Right. I just think people need to be aware that these trials are out there, and there's a national push for getting away from sentinel node biopsy for T1 patients. They're trying.
So you're talking ER/PR negative, positive, HER2 negative, postmenopausal patients mostly. So this is what we call at Mayo Clinic fondly the little old lady breast cancer.
Correct.
Right. And that laughs in the face of chemotherapy. Right. So the surgical treatment is your cornerstone.
Yep.
But they are getting radiation, and so is the idea of this that their axilla is being covered with radiation that might be killing some of that?
Right. They still are getting their radiation after their lumpectomy, but they're not including the axilla, not unless.
What?
Yes. And so and they're missing 9 to 11% of people, but they're saying survival is the same, which, okay, but then you're going to get an axillary, well, I wouldn't even call it recurrence. It's not an axillary recurrence, it's axillary disease that was there that you never found. So I'm not telling people to change, but we could all go back and read this. Again, Monica Morrow is considered sort of a national expert, but there is a push to not do sentinel nodes on T1 patients, which by far, I'd say that's the vast majority of patients that I have. The little old lady with the hormone positive breast cancer. How we are handling this, I do have, especially the choosing wisely is really pushing to talk to women, especially over the age of 70 with these T1 tumors, talking to them pre-op and saying, here's your risks. Do you want a sentinel node biopsy? That's taking it beyond just postmenopausal. Postmenopausal people, that's people over age 50, right? But they're choosing wisely is saying you should lay everything out for your patients over age 70 and let them decide if they want a sentinel lymph node biopsy.
Yeah, well, I love it. So it becomes very customized, which is what we're all aware of, and it should be that way. I mean, if you're a doctor, you know, you choose different things for yourself than maybe like the standard thing, and so maybe that means we should just educate the patients more. It just takes a lot of time. It's hard to do.
Right, but if you want, I would say if you want to run a breast program in your rural center, number one, I believe it's very doable. Number two, you've just got to stay up to date on your NCCN guidelines. And watching these trials, again, I would not recommend that anybody right now say, well, I'm going to just follow the SOUND trial. It's still a trial right now. So you're not going to find that recommendation yet in the NCCN guidelines.
Yeah, stick to NCCN. I've got a thing going on right now in my practice that I think is okay for me to share this because she's sharing it publicly, but my nurse practitioner actually has breast cancer. I think she's 34.
Oh, wow.
And she's going through treatment. And I think that is going to lead to us over the next 5 years really leaning in to breast cancer. She's going to be able to speak to the patients with a lot of authority, having gone through it. And then of course I'm going to bring in, you know, the connections and the knowledge we're going to, I think that's probably a place that we're going to have the commitment that you were describing of just owning it, because it's once you get that point, you got, okay, Mayo Clinic trained surgeon from here and his, assistant who has been through it. It literally can't get more tailored in the approach than that. Now, the only thing is, you know, can I bring in a plastic surgeon to help me out? And then I think we're all set.
I really think you could, especially if you're looking at, you know, maybe it's a day a month, maybe it's 2 days a month.
How do you get that person paid and incentivized?
I think you just have to find someone who's passionate about it. I think that's even more, I mean, they obviously have to get paid for what they do, but I think you just have to find that's where kind of having some of these connections out in your regional centers that have these people and approaching them and saying, hey, this is what I'm thinking about doing. It's more about finding the person. They'll want to get paid for it, but if they truly love just providing that service, if they've got some connection to the rural community, those are the people that you go after. And that's what you got to do is find the right person.
Okay, I love it. Hey, I didn't go, usually I go into the technical details, like to the level of, say, there was a medical student that couldn't, you know,
right.
That wasn't there. There were a few things I didn't. So after you do those 2 injections, patient's asleep, prep, drape, do you prep the arm into the field?
No, I just prep the eggs. I used to, and then I found that I've never, ever wanted to move the arm. So,
so the arm's strapped out to the bed, and then you prep the axilla.
And the breast.
And do you go up like above the clavicle? What are your landmarks for prepping?
You know, if I'm doing mastectomy, like let's say this is a bilateral mastectomy patient, then we're prepping all the way up to the chin, all the way down onto the abdomen. And then they have those beautiful, like clear plastic sticky U-drapes, because especially for mastectomies, you know, you're going way down. And so I found that just the other like the little blue sticky drapes just don't stay put. So if I'm doing bilateral mastectomy, then I'm doing those big clear plastic U-drapes to really get a decent sterile field. But if I'm doing just a simple sentinel lymph node biopsy and lumpectomy, so breast conservation, I'm just squaring it off with the sticky blue towels and that's it. But I just include breast and axilla, that's it.
So usually what I do for my incision for the sentinel node in the armpit is I mark out the hair-bearing area, and usually just like the anterior, inferior area, I make an incision right at the edge of the hair-bearing area. But I always listen first. Do you have any other tips on how to make your incision, or do you do it just like that?
I listen first, obviously, but almost, I'd say greater than 90% of the time, it's in that deep crease that is exactly what you just described. And even if it's off a little bit, I still tend to use that deep crease because cosmetically it looks awesome. So,
are you making sure now that you always get 3 nodes?
No, you don't have to get 3 nodes. So even 1 node is considered acceptable. So the one caveat to that, let's say you had a patient get neoadjuvant chemo and then they come back. So even these days, even if you have a positive node, it can't be like clinically positive nodes like matted lymph nodes. That would be excluded from this. But let's say you find on your pre-op ultrasound of the patient that they have a suspicious node and it's biopsy proven positive. That patient can undergo neoadjuvant chemo and then come to you and you can do a sentinel lymph node biopsy. So those patients, you have to remove that previously biopsy proven node. So you've got to have a way of localizing that. It could be with a wire, it could be with a seed, it could be with any number of things. But
and it had to be clipped at the time of the biopsy, right?
It's got to be clipped at the time of the biopsy, and you have to remove that at the time of your surgery, plus minimum. So you have to use localization of that node. You have to use 2 different tracers, whatever those might be, and you have to get a minimum of 3 nodes. And if you fulfill all of those things and all of those nodes are negative, then you're done. And that patient can just have a sentinel lymph node biopsy. So in that patient population, you've got to make sure you get 3. In all of our other sentinel node patients, if you have 1 sentinel node, so our requirements with the CoC guidelines is any hot node needs to go, any blue node needs to go, and any abnormal node. And that might be 1 lymph node, and that's okay.
The problem is then you maybe can't apply Z11 to that patient. That's why I asked.
We still do. Yep.
Okay.
If that's it, if you have 1 node and that node, but you followed all of those guidelines, and we have to document, we have a little templated dot phrase for the CoC guidelines. If there's 1 and it's positive, that patient gets referred for radiation therapy to the axilla.
So if it's 1 and it's negative, I'm pretty comfortable with that. But if it's 1 and it's micrometastatic disease, then it's just radiation. But if it's 1 and it's macrometastatic disease or extranodal invasion or one of the criteria, then those people get axe dissection?
You can have a macromet, but I would say not extranodal extension. Extranodal extension, I would at least do additional imaging before I made that decision. But let's say it's a macromet. For macromets now, even if you have 1 or 2 positive, it's radiation only.
Okay, well, we're going to have to make this an annual thing because it's hard to keep up on. Okay.
Yes.
Okay.
They update NCCN guidelines monthly. So it's
right.
Keep that on your computer.
Technically, again, for that medical student, okay, so we make our incision, we go through the clavipectoral fascia, we track down using a neoprobe, C-track machine, whatever thing, if you're doing, you're tracking down onto a sentinel node, dissecting it free. Do you clip the node? Do you tie when you dissect it out?
I clip the lymphatics and the vessels. I still do.
Okay.
Yep.
So you're using a teeny clip, basically?
Yeah, I think it's the blue clips at our institution. They're the blue clips. Yep, they're small. And then that just use cautery for all that. I don't want.
And you're just sending.
So I clip.
I understand. And you're not leaving a drain after a sentinel node biopsy.
Oh, and you're in axe dissection.
And you're not sending them for frozen or anything right then and there?
I do during my mastectomy cases. Because
you would go ahead and do a completion if there was positive.
If there were 3 positive, if I have 1 or 2, that patient can still get radiation therapy. So I still do just for the mastectomies. For the lumpectomies, I don't, because you could always come back.
Yeah. But you're not like in that same incision. Yeah, that makes a lot of sense. Yeah. And then if you had one that was biopsy proven and clipped beforehand, are you doing, in addition to your localizing technique, are you then doing a specimen x-ray to confirm the clip is in that node during the case?
I do. Yep.
All right. And then anything else technical before we start talking about closing up?
I don't think so, especially if you're looking at just a standard sentinel lymph node biopsy. Again, your criteria, all hot in whatever way you've localized, hot, blue, abnormal. That's it. The other, and this is a caveat, especially in the days of COVID-19 vaccines, just because it does cause lymph node enlargement. So once I've met with a patient and planned their surgery, I tell them specifically, do not get a vaccine, whether it be COVID or anything. I tell them, do not get a vaccine between now and your surgery, because especially when people were getting a lot of COVID vaccines, I had to take out 7 2 to 3 centimeter lymph nodes. They had a COVID vaccine in that arm. They ended up all being benign, but a 2 to 3 centimeter lymph node is an abnormal.
It's got to come out, yeah.
So I do counsel everybody, don't get a vaccine in that arm between time of seeing them in surgery, because otherwise you hate taking out that many lymph nodes.
Yeah.
So.
And then do you put any stitches below the clavipectoral fascia?
I only I don't even close clavipectoral fascia. I close dermis and skin. That's it.
Okay. And what suture do you use to do that, and what technique?
3-ovicryl interrupteds for the dermis and a 4-monocryl running for the skin and dermabond on the skin.
Thanks for going to that level of detail. I know it's kind of painful, but I think there are some of my listeners that really appreciate it. Yeah. All right, perfect. So, and I was wondering if we could jump ahead in our program a bit and actually go right to the resources for the busy rural surgeon, normally my last segment. But if you had anything that was specific to breast cancer and sentinel lymph node, do you have anything that are resources for us?
Again, I would say primary resource, if you want to be in the breast cancer area of treatment, NCCN guideline. 100%. You've got to use that as your primary resource. And that's what I refer my patients to as well, except the patient side of the NCCN guidelines. But if you follow those, people really cannot fault you for the type of cancer care that you're providing. So I would say that, and then you've got to find a way to do a multidisciplinary breast conference with, again, your regional center. And again, it's a matter of reaching out and seeing who's willing to include me.
Yeah, almost every guest that I have on talks about having a person somewhere else, like people that you're going to call that know you and all that. All right, perfect. Thank you. I was going to give the guests a bonus how I do it because I had an interesting case this morning. So I am on call, but it was not at the hospital. The surgery that actually happened was actually 8365 Lehman Road on the farm that I grew up on. So if you don't mind indulging me, I did do a inguinoscrotal hernia repair this morning on a 2-week-old piglet. So this is a common operation, uncommon location and type of patient.
Yes.
We had a bit of a hard time with our January litter. Long story short, she actually ended up getting out of her crate and had her litter in the hallway, and we lost a couple piglets. It's really sad. These are ones that are supposed to be going to show this coming up. They're spot pigs, and I think I can put some pictures if you're listening on Apple or Spotify. May want to go over to the YouTube if you want to check this out, but we can probably link in some pictures of the farm and the piglets. But yeah, so when you're doing an inguinoscrotal, it's a lot of similarities, right? But the nice part about doing a hernia repair on a pig is that you're castrating the pig too. So you're doing your orchiectomy, makes it a lot easier.
Yes.
So we have video and photographic evidence of this, but I can kind of talk you through the approach. So I was doing it with my dad. My dad, held the pig up by the back legs, and I brought actually a lac tray from my clinic, and I took it over and kind of set it up. I prepped with betadine. I made a vertical incision right over the top of the main bulge, and chased down through the soft tissues, surrounded the entire what is essentially a patent processus vaginalis, and then exteriorized the entire testicle and everything, and then excised the testicle, and then what I'm left with is hernia sac. So I clamped, but not getting bowel, and did a big twist move, and then I clamped up high, did a high ligation with a 2-0 chromic suture, stick tie, cut it, let it retract back up, and then I made a separate incision to take out the second testicle as well. Pig did awesome. It's almost like it's more bothered by being held upside down than he is by the incision. It's amazing what they can take. And then I just stitched up the bigger wound with a couple deep 2-0 chromic sutures, but not actually through the skin, and left the other one open to drain. So that's how you do an inguinoscrotal hernia in a pig.
Did you use local at all?
No. Yeah,
really?
You can make a cut. The pig didn't even react to the cut. I mean, he reacted to certain things, but once you get him upside down, he's kind of focused on hanging upside down. They do great. Yeah, I did prep it. I wore gloves, but and they're just so, when they're at that age, they're so blood supply is so amazing. They heal up great. Even though they're in a dirty environment, you would think there would be problems, but there hardly ever is.
And
the regular
landmarks, you just make your incision over the bulge, and that's okay.
And for the other side, I can identify the testicle and kind of slide it up and down, make an incision right over the top. Now, if I'm doing normal castration, a pig doesn't have a hernia associated with it. I actually usually do that at 7 days. Hold the pig in my hand, and fingers kind of going up underneath the two legs, so I push the testicles out the back end of the hog, and then I just use actually a side cuts, and I go clip, and we cut the tail too, so they don't, they'll chew them off, and it gets kind of nasty. They cut the tail, and then they just pop right out, and you can just pull them out. You don't even have to actually cut or suture anything; just pull the testicles out, throw them in the bucket, and then of course you clip their eye teeth and then notch their ears. That's all part of what we call like processing a hog at 7 days. The whole process maybe takes 3 minutes per piglet, I would say, once you get it down.
That's this. I must admit, I take that back. I used to take lipomas off of my dog when I was a resident in Chicago, because I certainly couldn't afford to take them to the vet at that point. So my husband would hold him down. I would bring home some local anesthetic and a basic minor tray, and we'd take off those troublesome lipomas. But
did you put a muzzle on the dog?
No, he was chill enough that he would not bite us.
That would scare me, but yeah. Very good. So that's rural surgery in a nutshell, and that is my real life. So I thought maybe the listener would enjoy that.
That is
let's carry on. We got 2 more segments of the show to blast through. First is the financial corner. Do you have a financial tip for our listener?
I was thinking I saw that was coming, and I know that you are way more financially literate than I am, but I have a daughter who just started college this year. I have a son who's a junior in high school. So again, looking at things like college tuition, I am so happy that we opened 529 accounts for the kids when they were born. Those accounts, you just stick the money there, and it grows and it grows. And actually we oversaved for both kids, which again, listening to all of my partners back when I was young complain about their kids going to college and all these expenses, I have to tell you, it's not even noticeable that I have a kid in college right now. So I'd highly encourage the use of the 529. You can transfer it between kids. You can even use it if your kid happens to go to a private school for 9 through 12. You can use up to $10,000 a year to cover that tuition. And then someone told me recently too, they can use it obviously for undergrad. They can use it for grad school. They can transfer it to their kids someday. So that's my tip of the day, is you will feel no pain when your kid leaves for college. So
yeah, that's a beautiful tip. I just had a buddy of mine tell me about his kid that's going from high school to college, and it's actually he's going to be feeling like he's saving money because of the money he's using through the 529. The other thing is you can actually use it for yourself if you want to take a course, a passion project or something later. So if you oversave in a 529, it could go to grandkids, it could go back to yourself. You're 60, you're retired, you're 70, whatever, you want to go back to a college and just take a pottery course or something, you can use it for that. So that's a great tip. I love that. Thank you very much. Last segment of the show for us then is going to be the classic rural surgery story. Do you have a story for our listener that your urban counterparts just wouldn't believe?
Oh, man. I was not prepared for this one.
It's okay if you don't.
Most of my best stories are actually, most of my crazy stories are more from CoC County Hospital, which is definitely a very urban environment. But I'll just briefly
tell me one of those stories that, I read an article said that rural America is the new inner city with drugs and poverty. And it's not completely wrong. Now, there's pieces that it's totally different. But yeah, just a crazy story because, we just like to hear them.
This is insane. So I had my daughter when I was a chief resident. And so she was about 6 months old for my first Mother's Day. So I had her in October. Mother's Day rolls around. I am the chief resident on trauma at CoC County, and trauma surgery is totally separate from the ER at county because it's just that busy. So my husband brought Potbelly subs to have, and my daughter, so that I would get to see her because it's a 24-hour in-house call. So he brings in subs. It's a beautiful Sunday. It's sunny. You would think that people could stop shooting at least for that amount of time, but no. So he gets there with her, subs are there, and immediately the nurse comes back and says, hey, we have a 000 gunshot wound rolling in 3 minutes. And my husband looks at me. He's never seen me do anything surgical. He looks at me and says, is this it? And I said, oh yeah, this is it. So a good friend of mine was eating lunch with us. She was not on trauma, so she stood and was the commentator. So my husband watched as I ended up having to clamshell the guy. So we did ED thoracotomy on the left side. Bleeding source was not there, so I cross-clamped the aorta, quickly went across, lifted his chest in a clamshell, and could see that his whole vena cava was blown out. So he'd bled out. This is an 18-year-old kid. So my husband and my 6-month-old daughter watched me clamshell a gunshot wound victim on my first Mother's Day. And I have to say my daughter now is a public health pre-med major at Loyola and is contemplating a career in trauma surgery. So those early life experiences for your kids are, leave a great imprint. To this day, I've been married 28 years. That's the only case my husband has ever seen me do. And he was absolutely horrified when it was over.
See, he thinks that's what you would do every day now, because that's all he's seen.
Right. Don't do that at all anymore, thank God. Obviously, the patient died. And I think what alarmed him the most was, I declared time of death because it was a non-fixable problem. I ripped off all my stuff and I looked at him, I said, let's go eat lunch. And he just looked like
how do you separate it? Yeah.
He might just rip my heart out some night while I'm sleeping, but
yeah.
Good news is
right.
Still married, 2 kids, and a full, wonderful career in surgery. So to any of the med students out there that might be listening, you can have everything. So that's my advice.
That is beautiful and a great way to wrap it up. Thank you so much for all the tips that you've shared. I really appreciate you taking the time to join us today.
Absolutely. Thank you so much, Dr. Lehman, for the invitation.
You bet. So thanks to our listener for being here. We appreciate you, and we will see you at the next episode of the Rural American Surgeon. Please don't hesitate to share this with anybody in your network that has a passion about rural surgery. We're here to fight the professional isolation and have a place just to come in and essentially create a rural surgeon's lounge for you. So thanks, and we'll see you on the next episode of the Rural American Surgeon.